actually have about 15 years experience treating pandas, and we were trying to recently collate our data, and I've seen about 2,500 patient visits. I'm a more in the trenches girl. So a pretty vast amount of experience, and it's just a matter of sort of pulling it all together to see, I think, what the right treatments are for most of these kids. Today I was just going to review sort of the whole spectrum of pandas from my standpoint, and go over the different approaches that I've had, and that really one size does not seem to fit all in these kids. I don't think that we're going to come up with a recipe for this diagnosis. The three major points that I really wanted to make today was that pandas is a tragedy not because of the lack of treatment options, but because of a lack of recognition. This can be a life-threatening condition, and it should be treated as such. And when there is appropriate management, really there is hope for a full recovery for most of these children. Most children will eventually outgrow pandas. It will just go away, or they'll have one small episode. But when they're not treated, or they're left to linger with chronic symptoms, with not enough attention or little attention or lack of recognition, they can become chronically ill from a psychiatric standpoint. So just reviewing the white paper, everyone knows about the white paper criteria. This was established after the 2010 meeting where several of us, Dr. Murphy, Dr. Kovacevic, myself, and a few other clinicians who I'm leaving out, came together and presented our patients and the way they presented with their different symptoms. And we had a 2-day throwdown, tomato throwing session, but there were about 40 or 50 people in the room, and eventually it was agreed upon that this would be the criteria. So one had to have either abrupt onset of OCD and or abruptly a severe acute onset of severely restricted food intake. That would be one of the major criteria, and of the minor criteria, had to have two of the following: anxiety, irritability, aggression, and or severely oppositional behaviors, deterioration in school. There's a whole variety of ways kids can deteriorate in school. Some children stop reading, some kids particularly stop functioning well in math. Handwriting is a major problem. Sensory and motor abnormalities, this is where we put the tics, because there was such a debate about the tics. But tics are a prominent feature of this. And then somatic signs and symptoms to include sleep disturbances, enuresis, or urinary frequency. I'm going to come back to this because these are the objective, the truly objective evidence of this. So the group that's studied by the NIH at ages 4 to 12 with the new first onset of the episode is also, by the way, the easiest group to treat. So they tend to generally get better, although they, I'm seeing some of the kids that I have referred to the second IVIG trial that Yale is conducting. And of course that study hasn't been broken yet, we don't know, but the problems that I've seen in my practice only is that some of the kids have relapsed due to recurrent infections of a different type. But overall, they're doing well. But if you get the kids early, they're very easy to treat. So just going back to what is the basis for believing that strep could cause this sort of an autoimmune process into the brain in the first place. We've known about this since the late 1800s. This is not a novel concept. Sydenham's chorea was described by Sir William Osler as patients having an excessive perseveration of thought in a textbook in 1904. This is not a new concept. It was just hard for people to get their heads around the idea that it was presenting in a slightly different fashion. So why do we treat strep? This is another important question to ask. Really, strep, if you have a strep pharyngitis, it's going to go away in about 3 or 4 days, whether you treat it or not. If you diagnose the patient with strep within the first 24 hours, you will shorten the course of the strep infection a little bit, but unless you get an abscess or some other complication of the strep infection, you're really not going to change the course of the strep infection if you're treating them 3 to 4 days in. We treat strep to prevent the autoimmune sequelae, the rheumatic fever, the carditis, the Sydenham's chorea, the post-streptococcal glomerulonephritis, and the reactive arthritis. I mean, this can go to the heart, the brain, the kidneys, the joints. So I'm going to review some cases just to give you a sort of a spectrum of what we see in the office. So this is be the mildest case, case 1. This is a 9-year-old who presented to the office with an abrupt onset of tics following a strep infection. And these children who present with tics following strep infection of the sort of PANDAS variety, although they don't meet the full criteria, a white paper criteria, don't present in a typical Tourette-like fashion where they have a few blinking tics and then the tics get a little bit more complicated over several months. They'll just wake up one morning and they have this huge explosion of all kinds of tics. So this child presented with an acute onset of an explosion of tics following a strep infection, was treated with a month of antibiotics, was put on preventive penicillin, and did well. That was it. That case, by the way, has been difficult because I would like to take the child off antibiotics and the patients are arguing with me. We're only on penicillin, so it seems pretty a pretty mood issue to argue with them about. But case 2, Emily, this was a nice little girl. She presented many years, about maybe 8 or 9 years ago now. She was in the 3rd grade, lived only about 3 or 4 miles from my office, presented with an abrupt onset of severe school phobia, extreme separation anxiety from mom. So a very social little girl, was going to preschool, no problems. Kindergarten, 1st grade, 2nd grade, suddenly, boom, absolutely wouldn't leave the car. And she had strep culture that was positive. She was treated with 1 month of antibiotics, high-dose Augmentin, and then dropped at the end of the school year. All of her symptoms resolved. We decided together not to treat her, and she did perfectly well for the next 2 to 3 years. And the family moved to New York. She called when she was in the 4th grade a few years later and had a recurrence of the same symptoms, was treated for another month of antibiotics. I gave her steroids for 3 weeks. She's now in the 8th grade and she's doing quite well. No further problems, no other complications. Now this is an extended family. This is sort of an interesting case, and this is sort of what you can see across the spectrum. There's a 7-year-old in this extended family who presented with a classic white paper criteria eerily on the day of his first communion. He was ready to walk down the aisle, decided his parents were going to die, he was going to die, everybody was going to die. The 4-year-old cousin, who was previously well, was diagnosed with PDD shortly after that. The father of the 7-year-old had a new onset of tics in his 40s, and the grandfather had, quote, an allergy to Augmentin, described as severe anxiety and panic attacks. Now, the 7-year-old was treated with antibiotics, finally resolved after all of his symptoms. His symptoms all resolved after his tonsils and adenoids were removed. He's now in college. He's doing perfectly fine, has no further problems. The 4-year-old was never treated, was never really addressed, was given some speech therapy, sort of accepted the diagnosis of pervasive developmental disorder, but the symptoms all resolved on their own, and he's now a healthy high school student. The father's tics went away. The grandfather's anxiety, however, remains, and he still is absolutely adamant in his belief that he is allergic to Augmentin. Case 4 and 5. Now, these are 2 sisters, and this is a case that these 2 girls were very, very sick. So the older of these 2 girls in the same family, they were both very precocious girls, very bright. The older girl was writing actual chapter books in 5th or 6th grade, full chapter books. She was quite precocious and suddenly developed severe OCD, anxiety, and, the family was just, she stopped writing. She stopped writing completely. She became completely dysfunctional in school. So we treated her with antibiotics initially, after she had positive streptitis, I believe, and everything resolved. And then about, I can't see now because I can't recall, but she did have a recurrence of her symptoms, and when it came back with anorexia. And the anorexia was very severe. She lost about 20% of her body weight within just a short period of time. So initially treated with antibiotics again, gave her some steroids. She got a little bit better, was tormented with obsessive compulsive thoughts, absolutely tormented. And this was a very religious family, so she felt horribly guilty about them. And it was just really very difficult. And treated her with IVIG. She had some improvement with the IVIG, But after about a month, she was not gaining any weight. Her heart rate was down to about 40. I said, that's it. Plasmapheresis, we have to make this better. This is not going to get better on its own. So she was treated with plasmapheresis, and she is completely well today. I mean, she's been well now for 3 or 4 years and remains on preventative antibiotics. Now, her younger sibling, who at the time, when I saw the older sibling, was completely well. So about 2 or 3 years later, the parents came in with the younger girl, and she presented in a completely different fashion. There was some different personalities, too. The older girl was the high-achieving, nerdy type of girl, and the younger girl was the more boisterous, outgoing type of personality. But the younger girl presented with this explosive, angry outbursts. She was trying to jump out of moving cars. She broke virtually every piece of artwork in the house. She broke her second-story window. She did attempt to jump out of the motor vehicle. That was a big problem. She wouldn't change her clothes. She refused antibiotics. We did IVIG in the office, actually, with an extreme struggle. It was not successful. She proceeded to lose 20% of her body weight and went to plasmapheresis. And she is now well on the recovery phase and is really completely back in school in the family as well. Now, I learned a very important lesson from this case. The dad had a positive culture for strep after we admitted the younger daughter for plasmapheresis. He never showed any evidence of anxiety beforehand, and I'm pretty sure we cultured the parents at least I gave them prescriptions for cultures multiple times before. Whether they actually went ahead and got them, I don't know. But the dad did culture, so he was whether that was causative to the kids. I don't know the answer to that. But the dad did test positive for strep. So Sam, this is a very interesting family. Sam is the oldest child of now 9 children. I have 4 families in my practice with 8 or 9 children in them. And it does seem quite genetic in that group because it seems to split right down the middle. There's about half of the kids in each family with PANDAS who developed it at one time or another. But Sam presented in a really severe way. They were all homeschooled, lovely mom, great dad, but she had extreme agitation, OCD, hypersensory problems, wouldn't change her clothes, wouldn't wash her hair, was violent towards her siblings to the point where she had to eventually be removed from the home. So she was living with her grandparents in a room at their grandparents' house, which surprisingly is not that unusual in these kids, and had food being delivered to her and through under the door in her grandparents' house, and meanwhile was emailing her siblings from the bedroom at her grandparents' house. So she wasn't completely dysfunctional from a cognitive standpoint. She was just terrified. So we started smuggling some steroids and antibiotics into her food, and that improved her enough so that she was able to come into the hospital for IVIG. She had some temporary relief and then relapsed, had plasma relapse, which gave her dramatic improvement. She completely normalized and was well for about a year, and then relapsed again. She was sent to a residential hospital for about 6 months, I believe, 3 to 6 months for rehabilitation prior to the relapse, but then she really did relapse. And after an extensive blood evaluation, she was found to have this antiphospholipid antibody. Whether that's significant or not, I don't know. The mom has it too. It's thought to be associated with miscarriages. She had 9 children. I don't know. But she is now getting IVIG, 1 gram per kilo, once a month with 1 gram of Solumendrol, and has been for about 9 months and is doing very well and has remained stable on that regimen. So Melanie is a little girl, is a young woman now, and this is the tragedy of PANDAS. And this is a young woman who I know actually because I take care of a younger sibling who has ADHD, and she came into the office and I was just asking about the other children that go to my church. I said, how's your daughter doing? Because I knew that they had had trouble with their daughter. So they told me the whole story. She completely changed in the 5th grade. It was sort of attributed to girl trauma, bullying, issues at school, social issues. They didn't know what had happened. There was problems. They went to a psychologist. They went to psychiatrists. They followed all the recommendations. They sent her to therapy. They put her on medications. They sent her to boarding school. Eventually, they sent her to a wilderness program. She started to run away. She got into drugs. She became pregnant. She had an abortion, and she has severe PTSD. The interesting thing and the most notable thing about this whole case is that the whole time that she was going through this, she had severe urinary incontinence. And I cannot believe that girl did not have an element of PANDAS. I just can't believe that she didn't. And this is a family who had the resources. There was just no awareness as to what else could possibly have been wrong with her. So, when children with PANDAS get sent into psychiatric facilities with separation anxiety, they go crazy. They really, really escalate. So I think this exemplifies the fact that we have this major problem with the lack of a psychiatric facility that can provide the medical care for these kids, and the lack of a medical facility that can provide the psychiatric care in one place. Because I've had children just sitting in emergency rooms for 2 or 3 days waiting, where can I go? What can we do? Well, McLean in Boston actually was kind enough, Dan Geller, to admit somebody and discharge them once a month for IVIG. So, we have made, some headway with things, but it's kind of not doing things quite the right way. We're trying to go around the system as opposed to making a new system that works the best. So case 910, this is a 6-year-old classic PANDAS symptoms with acute onset OCD, not in school. And I would, again, this is another thing that I would comment is very, very classic with these kids. I have been practicing for 25 years. This is a disease where the kids are often not in school. Not in school. Not only are they not in school, but the parents could care less if they're in school. Even kids, when they have leukemia, the parents want to learn about school. With this, they don't care about school. They're like, school? We don't care about school. So this child had recurrent strep pharyngitis, had tonsillectomy, augmentin, IVIG, dropped back to penicillin for prophylaxis, and a 2-year follow-up complete resolution of symptoms. The reason I brought this case up is that when the mom came back to see me, this was a case from Pennsylvania, she said, what's really interesting? My 4-year-old used to have pervasive developmental disorder and doesn't have it anymore. So this is where I wanted to segue a little bit, because I think that it's very important to note that, and this is something in neurology that we understand, diseases across a lifetime in neurology are not the same, because we have a changing brain. And I wanted to use just 2 quick examples of that. So people who have migraine is a very common disorder. It's genetic. You're born with it. You're going to either have it or you're not going to have it. Infants, sometimes will vomit, go to sleep, that's it. A toddler has this weird little presentation where they get all dizzy, and it's called paroxysmal vertigo. They drop to the floor for a few minutes, get up, and they're fine. Children between 5 and 10 have lots of vomiting. They vomit like crazy. They go to sleep. The episode revolves quickly. Teenagers start to have more of the typical headaches and vomiting. And as kids get older, and it peaks between the ages of 20 and 50, and then as people get older, sometimes they'll just have the visual symptoms, and then they have no headache anymore. So this is something that, as the brain changes and evolves, the symptoms completely change and evolve. So with an autoimmune encephalitis, I don't know why we would think it would be any different. There's no reason to believe it would be any different. So, and the same thing with absence or petit mal seizures. People have all heard about these little seizures. Again, you're born with that gene. They start around age 5, they go away at age 12, and that's it. So it's just like teaching a child to read. It'll take you 4 years if you start at age 2. It'll take you about 2 weeks if you start at age 6. It's like when the brain is ready for something to happen, it's going to happen. If it's not ready, it's not going to happen. So, and the question is, why does this happen? It's because the brain is myelinating. We have the outer surface of the brain is gray matter, which is basically like the little cells that talk to each other, and then the inside is the white matter, which allow the cells to communicate with each other. And that white matter, which allows the cells to communicate with each other, is what develops over time. And that's why the boys who have like this no frontal lobe development, because they're not myelinated in their frontal lobes, do all these stupid things. So they're older, and the girls are taking over the world. So the younger the age, the more dysregulated the symptoms. And now I'm going to make an argument here that a lot of people would disagree with, and I'm happy for them to do so. But autism is wildly on the rise. It was when I grew up in a neighborhood about 45 minutes from here, just south of Boston, and there was a big Irish Catholic neighborhood, probably with about 100 kids in it. There was not a child in that neighborhood with autism. Now it's 1 in 88. The recent studies is 1 in 50 on surveys. Something's going on. At first, the child neurologist tried to deny it, saying, we're just diagnosing it more often. And then they said, well, maybe, but it's clearly more prevalent. So the question is, what's going on? So my question is this an early presentation of an autoimmune encephalitis? It looks a lot like PANDAS. These kids have a loss of or a lack of acquisition of language. They're in a cognitive fog. They have extreme anxiety and aggression. They have abnormal movements with autism. They have OCD. They have major sensory issues. And sleep is a terrible problem in kids with autism. They don't sleep at all. So this is a question I think that just needs to be at least discussed. I think when the kids present at age 4 to 12, the development is more present. So there's more development present, so there's more to lose. Handwriting skills can be objectively looked at. Children are toilet trained. Most are sleeping in their own beds. Their personality is established. Age 12 to plus, they're better defended. They can keep their symptoms hidden a little bit longer. The girls are often silently suffering with the OCD, their thoughts. They can just keep it quiet. A teenager girl will come into your office just looking burdened. The boys are acting out and extremely impulsive generally. And either can have the anorexia. The anorexia, though, is different than typical anorexia. This is not anorexia associated with body dysmorphic disorder, typically. These kids say, I just can't eat. I just don't know why I can't swallow. Well, we know that they had abnormal swallowing studies with Sid and Nam's Korea. It takes actually quite a bit to coordinate the swallowing reflux. You have to form what's called a bolus or a glut, of food in your mouth. Push it to the back of your throat and swallow it. Close your trachea. Make sure it goes down. That takes a lot of coordination, and that's what these kids usually will present with. And then the handwriting issues. I have a few, and they're not as good as I had hoped they would come out. But the handwriting issues of PANDAS. When you've seen PANDAS handwriting, it's like, that's PANDAS. This wild looking stuff over here where everything is overlapping is fairly typical. This is a pre-treatment case. These just did not come out too well. That's the same case post-treatment. Pre-treatment case, post-treatment case. I got a better one. This person wouldn't draw anything. And then, that's not unusual. They're not drawing anything. And then this is what she's able to do afterwards. They have no respect for any spatial lines. Capitals, smalls, doesn't matter. It's all over the place. And they don't close their letters. Big O's and A's remain unclosed. And that was the same patient post-treatment. This over here is classic PANDAS. You see that big mess? It's just like this big mess. And if you start looking through the journals or the kids' school records, and I have them bring in their whole backpack, and you start to see the teachers writing, write neater, please write neater, please write neater, please use your capitals, please use periods. And this is the same case, post-treatment. So this went to this. So these kids get better. Now, the urinary frequency in bedwetting is another what I consider clear, objective sign of this disorder. There's really very little in the differential diagnosis of this when a kid comes in and says they're peeing all the time. They either have a urinary tract infection, or they have diabetes, or you say, I don't know what's going on, and you send them home, and that's usually what happens. And I've had one child come with a diagnosis of, oh, she has urinary frequency syndrome disorder. I said, that's not a disorder, you know. So, we have to start looking now at the urodynamics on these kids, because the question is it central coming from the brain or is it peripheral? It seems to me that there are two different types of urinary kids who frequently urinate and are damp and wet all the time, and other kids who just flood. And I had one child who came in and had a huge accident in the waiting room, another huge accident in my office, and another huge one in my examining room. So I think we have to start looking at some lab studies to see if these are central, which would create some low sodium levels in the blood, or they're peripheral, like from spastic bladders. But the older children I see sometimes who come in and have a huge PANDAS episode, if I go through their old pediatric records, they'll often be like, not often, but occasionally there'll be like a pediatric visit for urinary frequency. And they've had a urine checked and dipped, and they went home and they just got better, and it went away. And that might have been an early first episode. So who has PANDAS and who doesn't? This is a difficult clinical issue. Abrupt behavioral changes in a child can be due to abuse, bullying, family problems, all kinds of other things. And we have to pay attention to that. I have there's a lot of stuff on the internet about what the criteria for PANDAS are. And if you want to have PANDAS and get better, you can say that you have all that stuff and come in and get the diagnosis. But you really have to take a careful history, because you can miss kids who are being abused and other things. So you have to examine these kids and look at them. And there's no substitute for taking a careful and exhaustive history. Obtaining school records in pediatrics, including growth charts and walk-in clinic visits, is very important. You have to look at the neuropsychiatric testing. When you look at neuropsychiatric testing, I would suggest you look at the Rye-Oesterreich diagram test. You can take a kids who they'll frequently have gone in to have a neuropsych test to see why they're having trouble with math or school. On that one subtest where they have to copy a figure, a complex figure, they completely tank that with this disorder. And ask about family history of autoimmune problems, particularly to strep. In these families, there's a much higher incidence of rheumatic fever, Sydenham's chorea, scarlet fever, other patients with histories of, and you have to be careful about how you ask. Has anyone died of heart disease when they were 30? Yes. You know, and recently I just saw somebody whose father actually had just had a heart transplant, and said, well, we had a lot of stress in the family in the last 6 months because his father just had a heart transplant. I said, really? Well, why'd you have a heart transplant? Well, I don't know. I just started to slow down when I was 6, you know, in 5th or 6th grade. So, Mandy, I don't know if he had strep carditis or not. I don't know. But you have to be, you know, just asking about, do you have an autoimmune problem from strep in the family? You have to dig a little bit deeper sometimes. But generally, I like to put your money on the objective criteria. Are there sleep issues? They have trouble falling asleep, staying asleep, interrupted sleep, nightmares, night terrors. That stuff should go away by age 5, not start at age 7. Is it sudden onset? Do they have dysgraphia, handwriting problems, the urinary symptoms, the tics and the abnormal movements, and the baby talk and regression? We didn't talk too much about that, but they'll often be a 10-year-old carrying a little baby blanket into the office with them. So on the exam, the most notable part of the exam, I would have to say, is that the children look burdened. These do not look like happy children. They just look burdened. Sometimes they look terror-stricken. They are hypotonic, meaning they can be sitting like slumped over in the chair a little bit. Choreiform movements are often present, so that if you have them stick their hands forward, they'll have these wiggly little movements with their fingers. You can do that when you're 4, but you shouldn't be doing it by the time you're 9 or 10. And if frank chorea is present, it is Sydenham's chorea, unless it's lupus or another rare neurologic condition, of which there are some, and you have to look for those. And then how do you decide what to do? Well, it's based, the way I operate, it's based on the severity of the disease and the number of exacerbations. First, you examine the patient. You have to look at the tonsils. Do they look like they have chronic tonsillitis? Do they have tonsillis, little stones in the tonsils? Is one tonsil a lot bigger than the other, suggesting there's an abscess in it? Look at the ears. Are they retracted? If their ears are retracted, it might be that they have big adenoids, if the eardrums are not draining. Look at the skin. A lot of kids will have impetigo, all those little, things around the nose that the kids get in the winter when they get strep in the nose, and it just looks like acne, but it's actual staph or strep. Sometimes you can have guttate psoriasis. It looks like eczema, but it can be infected with strep and can be cultured. You have to look in the perianal region. I've seen many kids with perianal strep. You can also have vaginal strep, and penile strep is not at all uncommon. I ask every child if it hurts when they pee, and they all look at me like I'm crazy, and I try to reassure them that I'm not doing it just to be weird, but because strep can be in that location. Listen for a heart murmur. I have sent hundreds of these kids to cardiologists. This does not seem to be the same strep that causes rheumatic fever. None of the echoes have been abnormal. They don't have the same anti-CHO antibody that has been seen in rheumatic fever, but I still send a lot of them to cardiology. And look at the growth curves. You have to look at the growth curves. Remember, even a 5-pound weight loss and a 50-pound child has a 10% weight drop. So you have to be careful not to miss anorexia. And culture everything, the throat, rectum, and the family members. And when I do labs, I try to keep it simple. I do the strep titers knowing that even in the 1960s, people argued about whether they were always positive. Even with rheumatic fever, they were often negative. So Madeline will talk more about that, and I'll leave that to her. I do quantitative immune globulins and look for immune deficiency. Dr. Sweeto and we've had a couple conversations about this. These kids tend to have IgG levels that are in the low normal range. They might not be below normal, but they're not high either. They're just like barely hanging on. And I do an ANA, and they are frequently positive. But you don't want to miss lupus, which can present as an acute psychosis. And we do copper and ceruloplasmin to rule out Wilson's, but honestly, I think we overdo that a little bit. I do too. If you examine a patient and they're not hyperreflexive, they have really high reflexes, they don't have Wilson's disease. But it's a simple test to do. And vitamin D levels. Vitamin D levels are very important. Vitamin D is now being more and more associated with autoimmune disorders. You're not the only ones up at 2 o'clock in the morning looking at the internet, but there was actually a study in the veterinary literature where they sacrificed rats. They pre-programmed rats to become asthmatics, and they gave half of the group vitamin D supplementation, and the other half they did not get vitamin D supplementation, and then they carved up their lungs after they killed them. And the group that got vitamin D supplementation had normal lungs. The group that did not had all kinds of abnormalities. So vitamin D is an essential vitamin. And they took it away from us 20 years ago, and they told us we were all going to get skin cancer. So we never wondered about what the sequelae of that was going to be, and that might be part of the issue here. I think there's a lot of things we don't know. So how aggressive should we be? I think it depends on the severity of the symptoms and the length of the illness. If it's the first episode, there's no dangerous behavior, a month of antibiotics to start is a good way to go. If a month of antibiotics is not working, you can supplement with prednisone. The fear is that prednisone will make people psychotic. And it does sometimes, frankly. But in these kids, it usually doesn't make them as psychotic as the other kids. And I tend to give it all in the morning, or in the morning, and it's no later than 3 o'clock in the afternoon, so as to not interfere with sleep. And I usually will give a 3 or 4 week course, just because I don't want to give it for 5 days and have them get another illness and it be confusing as to whether or not the prednisone worked or it didn't work. The prednisone will not work the first week. That's a key issue. It won't work until week 2. So you start the steroids, and then it dampens the immune system, and they start to get much better the second week. I will usually start at 1 to 2 mg per kg, but I never give more than 60. Usually find a place between 40 and 50 milligrams. Check those vitamin D levels, and I supplement them. And the normal vitamin D levels are 30 to 100. I get everybody over 50. If they're doing dangerous or impulsive things, this includes jumping out of moving vehicles, not uncommon at all, running across lanes of traffic, hurting siblings, grabbing knives, threatening suicide, etc., immediately starting antibiotics that move quickly to IVIG and to plasmapheresis. It's too risky to try steroids in this group. It doesn't usually cause a worsening of behavior, but it can. And if they are already doing these things, you have really taken a chance putting them on steroids. And you can do it in a controlled environment like a hospital, but you can't. There is no hospital to put them in where they can get the medical care and the psychiatric care. So you really can't take that chance. So I think steroids you just can't get away with it in this group. I would say this kind of dogmatically. I say I do not under any circumstances attempt SSRIs in this particular group. Or stimulants. Sometimes the kids are diagnosed with ADHD, and in this group of kids, their dopamine levels are already through the roof. And when you put them on Ritalin, they become psychotic. You may actually make them psychotic. So you have to be very careful about these things. You can get away with a couple of medications without any difficulties at all. You can get away with the antipsychotics, which actually lower dopamine. So Risperdal, the neuroleptics, those types of medications. And you can get away with the benzodiazepines, like Valium, and generally speaking. Not always, but generally speaking. But Risperdal is pretty much guaranteed not to cause any problems and is most likely to help. The anorexia with significant weight loss, I consider this a medical emergency. I admit anyone who loses 10 to 20% of their body weight, and they often have low heart rates. Their heart rates can be 40, 30, 40. And if you have a kid who doesn't have a lot of fat and they lose 10, 20% of their heart weight, they're losing muscle. And some of that muscle is their heart. And this is dangerous. And you have to take it seriously and be aggressive. And in this particular group, I think plasmapheresis is the treatment of choice, because often if you do IVIG, you can get a little flare after IVIG. And I don't think these kids can afford that flare. I think they just ought to be treated in a controlled environment with plasmapheresis. They also need a cardiology evaluation. Tonsillectomy. This is appropriate with recurrent pharyngitis, asymmetric tonsils, cryptic disease-appearing tonsils. Tanya Murphy in Florida published a study. It was a very nice study showing that tonsillectomy did not prevent the development of PANDAS. It also showed, however, that the children who had tonsillectomies presented 1.5 years earlier than those that had not had tonsillectomies. My question, I wondered in that case, were the tonsils diseased earlier, which set them up for PANDAS? Like, why was there any difference in age? So I think that's a question that remains unanswered. This is a slide from Pat Cleary's lab. This is the group from Georgetown. We're actually sending the tonsils to him, and that we've taken out in kids with PANDAS, and he's looking at the IL-17 levels, and this is this is the control group down here. So that's a control group. These are kids who had their tonsils just taken out for obstructive sleep apnea, and these are kids with PANDAS. And there's a few other kids here, an autistic kid and a kid with, but this is a big difference, and the p-value is 0.003. So he wants to get more things before we confirm this, but these are from different centers now. They're not all just from Georgetown. So what is IL-17? This ratio of IL-17 over Th1. IL-17 is the big marker for multiple sclerosis. Multiple sclerosis is it's the sort of model disease for when the blood-brain barrier goes wrong and antibodies cross. And the Th1 is an important pathway in the immune system that assists in killing bacteria. And I'm not going to go into this with Madeline Cunningham here because she can explain this further, but the fact that the blood-brain barrier is theoretically open and the ability to kill bacteria inhibited raises many questions regarding the immune dysfunction. In these kids' tonsils, if the IL-17 is high and the Th1 is low, are they actually more vulnerable to infection and open up the blood-brain barrier at the same time? I don't know the answer to that question. And IL-17 is also implicated in asthma. So what are the questions at hand? Why do we see a major increase in autoimmune disorders in children now? PANDAS is seemingly new, or is it? I mean, we've known about Sydenham's for over a century. We have food allergies on the rise, like in anaphylactic reactions and all this Kids are allergic to all sorts of things. Eosinophilic esophagitis is a completely new autoimmune disorder. Completely new. Didn't exist 30 years ago. Different possibilities. Vitamin D deficiency. Vitamin D is an essential vitamin, so we already discussed that. I wanted to bring up Flonase. Flonase was invented in the late 90s, and it's used pretty widely, spraying steroids up the nose. And I just wonder if it's really such a good idea to suppress the immune system in the nasopharynx. I don't know. That's another question that I have. Aspirin was used as an anti-inflammatory and stopped due to fear of Reye's. And actually, it did cause Reye's syndrome. There was a little bit of controversy about that because a situation in Australia where they said, well, we don't use aspirin in Australia, but they used a drug that was very similar to aspirin in Australia. So aspirin is still a little scary drug to me because we did see children die from Reye's syndrome. Now, our food supply has completely changed. All our meats are being injected with antibiotics and steroids. Is this making the strep more resistant? Does it have more super antigens? Are we giving steroids to everybody on a low-grade basis all the time? Or is this simply like, quote, global warming? Like this is just the ebb and flow? Like we had a big episode of rheumatic fever in Utah several years ago. Are we just experiencing something that is just the normal, changing with the times? And this is going to go away after we fight this gigantic battle. But there are a couple of interesting questions, observations. Why do we never see, I only have 1 or 2 African-American children with this disorder. 2? Andrea says 3? 3? Out of hundreds. This has been observed by a few other people. So sometimes it's not what you see, it's what you don't see that you have to pay attention to. One of these children who was adopted did have sunscreen all over them every day. So I don't know if they have better vitamin D or I haven't tracked this close enough because I only have had a couple. Why do these children tolerate antibiotics? That's a whole different thing. If I have someone come to my office with a sinus infection, I try to get them to take 3 weeks of Augmentin because they have severe headaches from a sinusitis. They'll 10 days into it, guaranteed call because they got belly aches and they can't take it. These kids can take Augmentin, 60 milligrams per kilo for 10 years and never have a single problem. There's something different about the flora and the gut of these kids that allows them to take antibiotics for extended periods of time with no problems. And I don't understand what it is, but it's being studied now, needs to be studied and looked at. And in fact, if they are constipated to begin with, they usually get better. If they had diarrhea when they started, it usually improves. Whether or not they take probiotics, they often blow off the probiotics. They finally admit to me when they come in. So I just wanted to close with this one quote from one of my favorite neurologists, Dr. Sir William Osler. The philosophies of one age become the absurdities of the next, and the foolishness of yesterday has become the wisdom of tomorrow.